Welcome back. And to kick off our second session, there's no better person than Diane. As you know, UPMC has actually been very, very far front of the curve, and especially with the idea of merging insurance experience with the providers. And from my perspective, you'll hear later, is always very patient and family focused. The health plan, I think, has been a leader in understanding what the patient/consumers' needs are and developing programs from wellness to sickness to take care of them. So I don't know if Diane really doesn't need an introduction to this group, but I'm very happy first for the sponsorship and second, certainly to have you share your thoughts. Diane?
Thanks, Tony. So hello. Ooh, it's a little sensitive. Hi. So great to be here and great to help Dr. DeGioia bring this group together and also bring the kind of expertise to town that I think helps us think through what are the things that we're really trying to do when we talk about improving outcomes in healthcare, both the clinical quality and cost outcomes. So how do we think about that? So what I wanted to do is I'm going to turn the conversation, slightly right angle it a little. And just by way of introduction, because I think that the overview that we're talking about here today is in the context of a world that's saying, how are we moving from a volume-based system to a value-based system? And if we're really thinking about what's going to matter in healthcare, the conversation of price becomes critical. So, Jamie's conversation earlier on how do you think about putting together competitive methodologies that allow you to price and get a price that is sustainable. But I'd also ask you to think about the fact that when you're talking about healthcare delivery overall, all of us want a robust and sustainable healthcare delivery system. Nobody is trying to say we want to go backward in terms of the kinds of services and capabilities we have in this country. What we're just saying, I think, is we want to make sure that we get optimal value for that. So when we talk about the fact that, Medicare payments, providers will break even on them, and Medicaid pays you under cost, and, if you have, people without insurance at all, there's very little payment. And so consequently, all this cost shifting we've talked about over the years to the commercial market is a real problem. As we try to figure out how we're not going to overpay in the commercial space, we have to talk about the sustainability of all. And that means we're going to need to take waste out of the system. So that means not only, administrative waste, which I think we really have to talk about how to do that, but we're going to have to figure out what's not necessary. And we're going to have to think about the combination of incentives that matter. So we're talking about incentives for provider systems and insurers, and we're talking about incentives for consumers and for the employer community. Because at the end of the day, the purchaser is not just the employer, right? And it's not just government. At the end of the day, it's the individual, right? It's the consumer who, through whether it's paying taxes or basically seeing wage compression because their benefits are taking up all the extra dollar, we really have to talk about how to fix that. So I thought I would just in case there was anybody who doesn't know who UPMC is in the room, and I thought there could be a couple, we are an integrated delivery system, as you know. And the health insurance part of the UPMC was launched in 1996. So we're going to hit our 20th anniversary soon of having a health insurance division. And what we've seen over time is that this particular approach has had viability for us in order to bring forward to the community what we feel have been competitive offerings, but it also has foreshadowed what's happening in the nation in terms of a lot of the work that's happening today and where a lot of systems are going. We are, for those of you who don't pay attention necessarily, and I don't expect that you're all paying attention to what the UPMC health plan's up to, but we have 7 licensed insurance companies. We have a lot of other companies that sit under this umbrella, and we have grown now to be the 2nd largest in the nation in terms of all insurance premiums that sit under a provider auspices. Kaiser's bigger than we are, but pretty much there's no regional health plan in the nation. We're bigger than a large number of the Blue Cross plans in the country. We offer virtually all products and services, and we have seen exponential growth across the last many years. And I think I hope that's because people have found that it's a value proposition that for not all, but for many, seems to work. So that's my real last commercial, but I did want to just set the context, because if it were not something that so many other entities in the country are starting to emulate, it maybe wouldn't be as valuable a conversation. But what we've seen in the last year is that exponentially the growth of what is called accountable care organizations nationwide has really skyrocketed. We have well over 600 provider-owned, whether they be doctors, groups, hospitals and doctors together across the country that have formed these entities. And a significant percentage of them have Medicare dollars that they're trying to manage. Many of them have commercial dollars they're trying to manage. And they're coming together sometimes with an insurer, sometimes not, often not. But they are working together to collectively look at total cost of care, with the goal being that they want to improve clinical outcomes as well as cost outcomes. So some of them have gone on to form insurance companies. There are well over 100 provider systems in the country that have formed insurance companies, and the number in the pipeline is significantly higher than that. One of the initiatives that UPMC Health Plan took on about 4 years ago is developing a joint venture with the advisory board in Washington, essentially helping other provider systems around the country form the infrastructure to build their own health plan, or to form an infrastructure to go at risk with another payer in their market, or perhaps many payers in their market. So one of the things I think is important to keep our eye on is what is this evolving system that's happening. So networks get a lot of attention, and you probably all read that, last year on the federal exchanges, 70% of all the networks people selected were considered narrow or ultra narrow. Fully 35% were ultra narrow, which meant it had well below 50% of the providers in a given region in that network. We're looking at what is the impact of that, and how are we thinking about value networks being built. And I would caution you to potentially stop using the word narrow network, which I see out there being written a lot, because essentially a conversation that I think we should be having is what's a value network. And that's the conversation I think that we should be taking forward, because then when you talk about a value network, you can begin to talk about, well, what are all those things that Jamie was just talking about, and how do we think about the reference-based pricing inside of that? Or how do we think about the bundled payments being offered? So we at the health plan had launched, Tony was very active in it, bundled payment for hip and knee. We put that together over the last couple of years, have watched the data come out over the last year in terms of how it worked, got every senior orthopedic leader person in UPMC together at that table, and Tony can tell you it was pretty, right? It was like, it was what devices, how much blood product, what kind of blood, how do we think about this to really bring together doctors and hospitals? And then what was the plan's role in saying, well, hey, if I want to get a better arrangement for my member on cost and quality, I'm assuming you're going to have these quality gate you go through, but at the end of the day, we have to save money, and if we don't save money, that's not a value proposition that's good enough. Improving quality is a really important agenda, but that has to be married for us to improve quality while you contain or reduce costs. So that has been an ongoing, really exciting, I think, development. Some of you may have seen the Brill Time Magazine article. This was the author that a couple years ago, Time Magazine devoted their entire magazine to what's wrong with healthcare, and he launched a new book. And you may not agree with all the things he said, but one of the things that we found interesting is that at the end of the day, part of what he talked about was the model of integrating care and coverage. And if you can begin to align the incentives between the payer and the provider, can you begin to have truly some better opportunity for people? So we have been interested in that. Now, the other huge driver that's going on outside of what's going on in the private sector is what Medicare is doing. And I always think, of Medicare as the mother of all payers. And my feeling is that we're seeing huge shifts in provider behavior related to Medicare. And when Medicare begins to marry the other government programs and begins to marry the commercial environment, I think we begin to see some significant changes. By 2018, virtually 90% of all Medicare payments are going to be related to quality, and they expect and will push a minimum of 50% of the payments being in some kind of alternative payment model. So global capitation, at-risk payments, things that actually speak to the provider community around looking at cost and containing costs. Quality is always critical, so a recent study again, says if you're going to talk about value, then you have to talk about what is that outcome you're getting for the dollar you pay. And the United States, as wonderful as it is in so many ways, and as wonderful as certain things about American medicine is in many ways, we also know that we sit kind of at the bottom of the heap in terms of industrialized nations across the board in our quality outcomes. So let's talk a little bit about what's happened. So healthcare premiums, we've seen the last several years, have not escalated at the rate they did historically, so that's a really good thing. Medicare, in its 50 years since it was invented, has never performed better in the Medicare fee-for-service environment in terms of cost containment, so that's a good thing. And when we look at the Pittsburgh market, I don't know how many of you, are aware of it, but if you look at commercial premiums in the Pittsburgh market, we are, of 25 top markets in the nation, we have the lowest commercial premiums here. And if you look at all 60 markets, we're third from the bottom in terms of lowest premiums. So Pittsburgh has been a well-performing market in the commercial space. Now, what does this mean in terms of household income as compared to what's happened with insurance premium? Still not a great story, because household incomes have not kept up and inflation continues to be a problem, and so real wage growth has not occurred, and health insurance costs continue to go up higher than we can afford, right? So we still have a problem, even though we've seen some flattening. So what's happening? What are purchases doing? What are we thinking about in this room? So what's an individual person asking when they're what's the biggest question I will tell you we get when people are looking at our exchange products and our other networks? Is my doctor in that network, right? The individual is pretty focused on that. What's a company doing? They're looking at various networks. There's choices in Pittsburgh. There's choices around the country. Most major markets have multiple choices in terms of networks you can purchase. And the employer is saying, well, if I got to buy for group, right, I want to make sure I got an adequate supply in my network of what I need. And so this conversation where a handful of years ago we were talking about everybody needed a big PPO, everybody needed everything, I think culturally we've made the decision that doesn't work and we're not going to stay there. Will there be backlash? Will there be problems associated with it? Of course there will be problems associated with this. But as we move in a direction that says the consumer is going to be willing to trade off certain things for a better price, this is going to be one of the things that we're going to be looking at for, I think, quite some time. So if we're going to talk about trying to get our hands around affordability, and we're going to talk about what it's going to mean over time. Of course, reference-based pricing would be useful. Bundled payments helps us in certain kinds of ways. Lots of different payment models. But at the end of the day, as the consumer gets more and more engaged, will I ever make a relationship between the pizza I eat and the price I pay for something in my healthcare costs down the road? Do I have any capacity over time to see a relationship between what drives the cost of healthcare up? Pricing's definitely one of them. We can talk about, provider consolidation driving, all the different things we can talk about. But there is a relationship to the consumer in terms of what kind of health status they have and what kind of health care they need and how they can get that at the most affordable price. So this is a sign not far from one of our hospitals that I stole from Dr. Parkinson. Basically says habits. It's where you can, after you get your MRI, you can pick up your beer and cigarettes. Chronic disease continues to drive 75% of healthcare costs in this country. And I'm just displaying for you the obesity maps on the top line. showing that the country gets heavier and heavier over time, and showing you the corresponding diabetes maps on the bottom that shows you, I'm not suggesting it's only causal there, but there is a correlation, and I think there's certainly a relationship that most of the physicians will tell you. Now, look at those other charts where, I don't have to tell the actuaries in the room or the people who study health employer benefits. You people look at these kind of numbers all the time, right? So you know that a very small percentage of people are driving a very big percentage of the cost. And you know that we've all been working lots and lots of ways in lots of methods trying to figure out how do you help people from moving up the curve from getting so expensive. And some people you're not going to prevent from getting very expensive. You might be able to control what the pricing is at the top of that line when they get that MRI or they get that cancer surgery or they get the kind of services they need. But there are certain people who are going to be expensive no matter what. How do we get better value for the purchasing, right? But how do we as a culture and as an industry, whether it's on the provider side or the payer side or the employer side, how do we actually begin to build a methodology that people care about this and see the relationship? Tony has told me repeatedly, if we could just do something early, I won't be doing so many hips and knees, right? I mean, what the data that he wants to look at with us is how do I go way upstream to those people the first time somebody complains of knee pain? So I can intervene 10 years before that surgery is going to be needed and maybe prevent it completely. So that's the kind of work that has to be done in that space. So this says, have you heard 250 is the new 180? Well, on some level, it's a little bit of a joke, but it's not really. People have to really look at these issues and wait, although for some people it's not really heavily in their control. For a lot of people, there's things that they can do. Now, one of the things we have not spent much time on, we talked about medical devices, we talked about reference-based pricing, we've talked about lots of things that can help control costs. This scares me more than almost anything. How many of you in the room have been watching the pharmacy trends in terms of cost? Okay, how many of you have looked at the pipeline for the biologics? How many of you have been negotiating with the pharmaceutical industry? So one of the dynamics here is that there are some medications that are life-saving and incredibly important, and if you had one of these horrible illnesses, or your child had one of these horrible illnesses, you would be beating down the door to make sure that you got the medication, because the quality of your life might as well be over without some of the help that these things can afford you. So no insurance company, no clinical doctor wants to stand in front of a life-saving or life-enhancing medication. But you can't have the cost trajectory at the level we have it, because it will eat up the entire budget of an employer. It will eat up it will be very, very difficult. So there's lots of strategies, right? We know lots of compromises have been made with the pharmaceutical industry around, them getting a pass on certain kinds of controls. We really have to look at what it is, because Sovaldi, although Sovaldi in and of itself, is not the issue. I mean, Sovaldi at $84,000, per course of treatment, and also Sovaldi being essentially the first drug that I'm aware of that came out that cures an illness, not just treats its symptoms, but cures it. And the ethical issues attached to it and the cost attached to it are really quite profound, and they foreshadow conversations we need to have. So there's a lot we have to get our hands around. So one of the things that we've been trying to think a lot about is how do we help employers? And again, stole it from Dr. Parkinson. He crafted an infrastructure at the plan over several years that really looked at the employer roadmap. What's the journey, and what are the things that if you're going to do a strategic plan as an employer and you want to get your hands around your cost and your outcomes, because if you're an employer who actually keeps your employees for longer than a year or two, if you're not one of these high turnover employees situations where everybody leaves you, what do you care about, right? You care that they come to work. You don't want them calling off every other day. You care that they're not sick. You care that they're productive. You care about them as human beings, but you also care about them as your important human capital. you can look at that group of people that you have an obligation and responsibility for, and you can make a difference in whether or not they stay healthier. So this plan that we drive with employers that are interested in it, and UPMC has engaged in this aggressively over the last decade plus, is really a roadmap that says put your money where your mouth is and pay attention to where your costs are being driven and how you're going to have some very specific strategies around those costs and those quality outcomes. So everything I talk about will have something to do with optimizing your environment for people, increasing healthy behaviors. So how do we do that, incentivize it? How do we minimize acute care? Because what we're trying to avoid is that expensive, unnecessary, unplanned care. How do we optimize, if people have a chronic illness, how are we going to optimize that they function? How do they not get a secondary, another condition based on the first condition they have? How do we prevent people from deteriorating if they already have a condition? How are you going to reduce excess surgery? Because surgery is a big cost driver. And what am I going to do when somebody is at home off and I need them back to work more quickly? How do I speed that back to work transition? And these are all strategies that we work in a strategic planning methodology with employers around. So I'm going to give you just a tiny example of UPMC, but we do this with a ton of employers. But we have a long-standing cohort. We've published this data. We've been looking at this data over years and really seeing excellent results. So, years ago, when we saw our healthcare costs, now UPMC, it's got 60,000 employees, right? So it's spending in excess of $300 million a year in healthcare costs. So trust me, we, like any large employer, are looking at our healthcare costs all the time and trying to figure out strategies. So when we, give our employees incentives and we say, well, yeah, you need an annual HRA. Yes, you need a biometric screening. We need to see that. Yes, you need to engage in activity, and we put in incentive-based plans for people in terms of incenting them to actually do these things. But we also need to see action, not simply just sort of assessments. And we've seen a lot of action. We had the good fortune to build a very state-of-the-art infrastructure for coaching, whether it be on-site or whether it be at the plan or whether it be in the employer or the provider space. And we've been able to do a lot of things with that kind of wraparound coaching. We target the things that are related to improving health. But we also have looked at benefit designs that have been, a variety of kinds of benefit designs. So we look at things where, essentially value-based benefit designs where we say, okay, now you've had process measures in the past. You had to do this, you had to do that, get your incentive, improve your health. But now you're going to have outcome measures. So for people who elect this plan, in order to get that incentive, which is a pretty hefty incentive, you basically have to actually show biometric improvement in certain categories. And that's going to be next year's new wave. And I think it will actually be something that, based on the groundwork we've done for years and the barriers we've taken down for people and the support and help we've been able to give them to do it, we think this is actually a good benefit design. We put something in and we programmed it in because when Jamie said earlier, who do people listen to? I can tell you they are not listening to their insurance company. They are not, if we call them up and say, yes, there'll be some set of people who will listen to their insurance company, but by and large, the most trusted person, when you ask people who will you listen to about your health care, it's not their next door neighbor, and insurance companies are one step above, I think, people who commit fraud or something. They essentially say, my doctor. And so what we said is, well, we're not gonna, as a payer and provider, what is our biggest asset, right? Our biggest asset is that we are integrated and that we actually try to think with one brain. So we try to think about what it is that impacts people. So our doctors, basically, are writing prescriptions for health coaching, not just the medication, or not just the procedure, not just the MRI. They're writing prescriptions for health coaching, for weight loss, for smoking cessation, for all the things, stress reduction, stress management. We know how much stress plays in a lot of chronic disease. And essentially, we built it into the electronic medical record, so the doctor doesn't have to think twice, essentially. So this year, we launched it into Epic, and now if somebody goes in for an assessment and they're agreeable, and the doctor asks the question, Do you want the help? And the doctor doesn't say, oh, I know this vendor somewhere that'll talk to you. The doctor says, my team includes smoking cessation people. My team helps you with nutrition. Would you like to talk to one of them? I know they're very helpful. Many of my patients have used them. It works really well. And the uptick in terms of the difference when a doctor asks you to participate and you're going to come back and see him or her the next time to get on the scale or talk about your smoking problem, you have a trusted relationship, it really helps and matters. And the percentage of people who then engage has been dramatically increased. So these are just some stats in terms of over time. We've studied this year in and year out, big cohort of people seeing improvement both in the actual activity, so smoking cessation way down, cost per member when we look at the people who smoke versus not smoke and the ones that quit, how much can you save it? We monetize all of this. And we basically look at our trend every year like everyone else does. And you can see, I mean, we tend to run well below the industry average for healthcare provider systems. We have medical trend that we benchmark. Every single year we go out to an independent entity and ask to benchmark against it. And we continue to run very well in terms of trend. And this year's trend is, -3. And that is a combination of the programs we offer that help you, but it's also a combination of the benefit design methodology that we focus on repeatedly to make sure we keep costs affordable for our employees. Now, the other big thing we do, because we're looking at integrating care and coverage, is we say, okay, well, what has to change in the delivery system? What is the most important thing? If you're going to start to help people, what are you going to do? So we said we want a very strong foundation of primary care. That's going to be a foundation for us. We're going to build medical homes. We started that years ago in this market. We're in 400 sites with our medical neighborhoods, we would call them, because we don't think of this as just primary care. We think of it as primary care related to specialty care. And this is where the doctors and the care managers in those offices, and we put care managers in those offices with the doctors, have data in as real time as we can get it, both data coming from the clinical side and data coming from the payer side. And we've seen in our mature practices a reduction in cost, improvement in primary care goes up, and what do we track? When we say, are you a successful medical home? Here's what I want to know. Did the quality go up? And I can tell you virtually always the quality goes up. But did you reduce my inpatient hospitalization? If you have a panel of 3,000 of my members, has my inpatient acute care gone down? Because if you're doing the right things in wrapping care around people, then I shouldn't see the readmission rate be high, and I shouldn't see the acute care need be as high, right? And we benchmark ourselves against 500 health plans every year. This is an independent benchmarking group, and UPMC health plan for our PPO product is sitting below 40th percentile in the nation in terms of medical discharges from acute care. That's a really good, I'm proud of that number. I think that's a good number, and it continues to be something we're going to continue to focus on. Readmission reduction, why? Because we're going to help you in the transitions of care better. Back surgery, another great example. We said, hey, we don't think our back surgery rates look where we want. We basically went to the surgeons. We said to them, hey, we're going to put in a different methodology. We're going to actually ask for a 30-day period, unless there's some cases which you just have to go immediately to surgery, but let's assume you don't. We want to see people in PT, and when we looked at what was interfering with that, people said, I can't do 6 copays. I'd rather get the surgery. So it's cheaper. Back to Jamie's point. So we said, wait a minute, we're going to do a benefit design, and we're going to bundle 1 copay for that episode. And we're going to actually push you, and we're going to have the doctors push you. And we saw a 20% reduction in back surgery, and we saved a fair amount of money, and we continue to see this be an improvement for both cost and quality. If you're going to follow the money, and somebody's saying, okay, well, what costs me a lot of money, then you have to look at people who are very, very sick, because very, very sick people spend money. So you have to think about, what are we doing for end of life? I usually do a poll and say, how many people would like to die in an ICU? And this will be the first audience if somebody raises their hand and says yes. You know, what we want to do is find ways for people who are very sick to actually have a quality of life. And we care about this from a quality perspective, but we also know it drives a lot of cost, and they're unnecessary costs because there's limited amount of money, and if you spend it on things that are unnecessary, you can't actually help the people in the ways you'd like to. We know the whole world is moving to consumer-centric strategies, and we've been moving there aggressively. And so we can look at lots of ways that we've been looking at this. And our technology innovation team does a lot of development in this space, or partners with really great development. So we say, what's convenient for people, what motivates them to improve their health care, and how can I guide and help them? And will people pay attention to the electronic capability? So this was a little survey I thought was interesting. And it said, how long did it take to get 50 million people to use something? The telephone, it took 75 years. The internet took 4 years, and Angry Birds was 35 days. We think people are going to move with mobile. So we put in tons of mobile devices and capabilities. So you can look up on our pharmacy app, how long does it take me to get into urgent care? We basically built a stay at your desk, and instead of going to Walmart or someplace, stay at your desk and fill your prescription if you need to, because that sinus infection is back again. And so this is something all the health plan members have called, Anywhere Care, which is virtually available anywhere you are. Motivation, how do we get people engaged in the weight races? We've lost multiple whales at UPMC in weight races, and they've been very engaging for employees. We have 100 different uplifted devices you can put, so Validic is our product that we use that, we can do a lot of device uplift. We've been talking about transparency, and I agree, it is not a silver bullet, but it's one of the bullets you do need in your gun. And I think we're in a pretty early stage for transparency tools. We have launched a new one this year, which we think is light years better than the old one we had. I'd be happy to talk about what it can or can't do at this point, but I think it's really a very good tool. And we've done some other interesting things, like we contracted with this organization, Wiser Together. 20 million members across the country, right? It's like ask your friends. A little bit like Expedia reviews. Well, if you had this problem, would you be getting surgery, or would you consider taking some medication? How do you really have, shared decision support with your physician? Have you really talked? And one of the interesting parts of this tool is it actually has a group that's just doctors talking to doctors about what they would do. So that's interesting, because doctors don't always necessarily do what they think their patients might be doing. So it's an interesting tool. We also are working with our hospital systems, because one of the things we find is that when you're in the hospital bed, you have some time on your hands. And when you're going home, maybe one of the things that we could take advantage of helping you learn about your condition. So we have a SIM coach, a CHF SIM coach that we've been working with some of our hospitals to say, hey, I have congestive heart failure. What are the things that are really important for me in an entertaining and engaging way? So that's been an interesting thing for us. So I think when I look at what is going to be better in healthcare and what are the really future state things, I think we're talking about a world of technology that's going to help us. But as we've pointed out, technology can be expensive. How do we actually make technology work for us in the right direction? Are we going to enter a world where, a handful of years from now, 80% of what any of us needs is done virtually? We're probably not getting hip surgery virtually, right? But how much else will be done virtually? I think it's going to be a lot. But I also think that you can't expect technology to do your work for you exclusively, or you're going to have the tail wagging the dog. What I really think it's going to be the marriage of really the world of high tech and high touch, and I think we have been working on that aggressively. And my hope is that at the end of the day, it's really all going to be in the service of better value. So, thank you.